Assalamu alaikum. Thank you very much. मेरी आवाज़ ज़रा बैठी हुई है, so forgive me for that. And Bilal, I've excellent talk. I would love to do quads, but we don't have the gadgets here in Pakistan right now. But that was excellent. And I'm glad that I'm over 50 and still doing hamstrings, so thank you. Right, so it has gone up, going up. Okay. So ramp repair, they are a hot topic in today's world of orthopedics. Because very late, but we still recognize that they have important biomechanical consequences. And also that they occur much more frequently than was previously thought, really. I have so far still unemployed, so I have no disclaimer. Strobel in 1988 was the one who described and used the term ramp lesion. And he characterized that lesion as a tear in the posteromedial corner at the meniscocapsular junction, less than 2.5 centimeter in length. It was initially, the reason why it was missed was two, or maybe more. One, the MRI was of low sensitivity. Number two, when you do the MRI, your knee is in extension. So it means that the capsule at the back of the knee is very close to the meniscocapsular area, and the MRI was very difficult to pick it up. And as we know, the mechanism for the ACL tear, and it's actually at the same time that the increased valgus stress will cause this tear in this. But then there is concomitant or countercoup mechanism as well, where the relationship of semimembranous tendon are close to the capsule, and also the compensatory varus alignment and internal rotation of the femur after the initial pivot shift can cause these injuries as well. So our early understanding of the meniscus was it was a useless structure. You know, if there's a tear, remove it. So meniscectomy was the common procedure, the most commonly done at that time, and everyone was happy. But then we realized that this is not something we should be doing, because our early focus on any knee injury was on reconstructing the ligaments and not the meniscus, until we realized the importance of the meniscus as a load-sharing important structure that lies between the two bones. And there are many types of meniscal or ramp lesions. I'm not going to go with it, but it says that if you want to diagnose ramp lesion clinically, the gross pivot shift will only be positive in type 1 and 1, 4, and 5. So it suggests that you need to have a high degree of suspicion when you have somebody coming up with an ACL tear. So the first ramp was done by, I don't know my slides, I just keep moving. So in 1991, Morgan described a surgical technique for the first time for an arthroscopic repair of the ramp. And from 1991 until early 2000, it was kind of disappeared from the scene. Why? Because we had difficulty in identifying or getting into the posteromedial compartment. We had difficulty diagnosing the ramp lesions due to low sensitivity of the MRI scans. And then they started, we started seeing the failure of the ACL reconstructed grafts. So the more research went into looking for the reasons of those failure rates, which suggested that, listen, you did not treat the ramp lesion, so you left an instability in the knee, and that has caused your graft to fail. And many studies came up. Now, this is what I do. So a high degree of suspicion, you have a case, with an ACL, so you do your EUA, so your anterior drawer is positive. Then you go in and check your pivot, and 20 to 30 degree with tibial internal rotation. You start with an extension, go into flexion, and you would notice a 20 to 30 degree of flexion, a bit of pivot if there's or there's not. So I would always go for skin marking, anatomical landmarks. So my anterolateral porters are tied with the patella tendon. Anteromedial is slightly low as well. I would feel for the condyle and the junction of the condyle with the shaft for access to the posteromedial compartment. I would put a mark there as well, although when I'm doing it, I won't be able to see it. So once I'm into the joint, you need to identify the triangle, which is bounded laterally by the PCL, medially by the lateral wall of the medial femoral condyle. This is the probe I'm going in, and inferior by the tibia. And you would see sometimes a clear root, or sometimes you won't be able to see anything, so you need to get into that. And it's not easy, honestly. People who have tried in the initial phases of exploring this area have broken their cameras, have damaged the medial femoral condyle, have caused tear to the PCL, and so a lot of problems happen. And as our understanding is growing, we are trying to get into that space. So different techniques, Gilchrist, modified Gilchrist techniques, switching stick techniques, many techniques have come in order to get into the posterior medial compartment. Sometimes you might get into a knee which has a very tight medial compartment, so you might have to opt for a pie crusting technique or something to get into. So once you are into this is the view you will get initially. You would go into the posterior medial compartment, and then you need to rotate your camera and look for the soft spot. You have to be wary of the area, the neovascular bundle posteriorly. So as you look into it, you need to go into your spinal needle, because it is very important what we call now and known as the needle stick test. So you rotate your camera, you go into the posterior compartment, you put your spinal needle. Remember, the one thing I forgot to tell you is the ramp lesions are also famous as hidden lesions. So they are not always visible. So that's why this needle stick technique have come. So again, you feel for the soft spot, you are in with your spinal needle, you go over to the ramp area, and then you start scraping the synovial tissue to see if there is any ramp lesion or not. Your knee is in 90 degree of flexion in order to see it clearly. So once you go in and bang, there you go. You could see a ramp lesion in this area very easily. Now the next thing I would do is make a little hole, put a transport cannula, and go through with a curved device or a hook onto both sides of the meniscus, use a non-absorbable suture, and then throw some sliding knots, and then tie it over like this and secure that area. And so once he is done, there is no written consensus how you want to manage your patient post-operatively. The way I do it is keep them non-weight bearing for the first at least 3 weeks, maybe more, depending on the case. If I'm happy with my repair or not, I limit their flexion to up to 90 degrees for the first 6 weeks. So I wouldn't allow them to go beyond 60 degrees. And then gradually they will start having weight bearing and the rehab. So back to sports in about 7 to 9 months. So take home message. Any ACL tear, remember 1 in 4 ACL would have some sort of a ramp lesion, so high degree of index is required. A systemic exploration of the posteromedial compartment is a must, and if you leave your ramp untreated, there is a very high chance of your graft to fail, and you have to face the patient, or in Pakistan we say bach ke rehna, and then do the revision procedure. Thank you.